All of this is available on our website, bitemedicine.com, which should still be working now, but if there are any technical issues, as I said, we'll iron them out as soon as we can. So it will all be there, including the video, the slides, and we'll get the Q&As done as soon as we can as well. So this should probably last around an hour and 15 minutes. So let's dive right in to hypothyroidism. So the main objectives and aims that we have for today are going to be looking at our pathophysiology, differentials, investigations and management of hypothyroidism, as well as one key hypothyroid emergency as well. So that's what we're going to be doing today. If you could make sure that you have your phones handy as well, because we use an interactive approach with our questioning. And we also have some doctors in the chat who can try and answer your questions as we go along as well. Okay, let's have a look at our main case for today. Case number 1. We have this lovely, this is meant to be a lady, this lovely lady here who's come in with a hat on. A 36-year-old Caucasian female presents to her GP in London with ongoing fatigue. She's gained significant amount of weight and has been constipated as well. She looks tired, and you note that she's wearing this woolly hat despite it being a warm summer's afternoon, unlike today. So have a look at her observations and tell me what you guys think about those. Anything that stands out at all? Yeah. Good. Nice. So nice simple question. Absolutely. So bradycardia is the main thing that stands out. Everything else is essentially okay. In terms of the history, this is a characteristic history of hypothyroidism, which is what we will be talking about for the next hour or so. So let's dive in straight with a question. So as I said, these questions are on Mentimeter. So if you go to www.menti.com and you type in the code 106655, I'll start off with some straightforward questions. Let me hide those. There we go. Okay, so what is the most likely cause of this patient's symptoms who's come in with tiredness and fatigue and weight gain and constipation and a couple of other things as well? What do you think is going on? Okay, give you a couple of moments. Have a look. Nice. Okay. Good. So the vast majority of you guys think Hashimoto's thyroiditis. And you guys are absolutely correct. So the reason that this is that so Hashimoto's thyroiditis in the developed world is the most common cause of hypothyroidism. It's an autoimmune condition, which we're going to talk about in more detail shortly. The reason why it's not iodine deficiency, these are probably your top 2 differentials here. So iodine deficiency is the most common cause of hypothyroidism worldwide, across the globe. But this patient was from London, she's Caucasian, so she's probably British, from London, and UK has pretty good, people have pretty good iodine intake. A lot of our salt is fortified with iodine, for example. So in developed countries like the UK, Hashimoto's thyroiditis is the most common cause of hypothyroidism. The other options here, so de Quervain's thyroiditis is it's like a viral inflammatory type of thyroiditis. Patients usually present with preceding viral infective type symptoms for a couple of weeks. So that's unlikely in this case, and often they have a painful goiter as well. But we will talk about all of these conditions, all 5 of them, very shortly. So just to highlight the key points that pointed towards hypothyroidism, and particularly Hashimoto's, is her age. So there's a characteristic demographic for Hashimoto's is females, kind of middle-aged, 30s to 50s. It's unlikely to be iodine deficiency because she's in London, as we said, and all of her symptoms here, including heat intolerance, are symptoms of hypothyroidism, as well as the bradycardia as well, as characteristic of hypothyroidism. Good, so nice straightforward introduction. Here's another question. So we think this lady has Hashimoto's. Which of the following antibodies is most likely to be present? Anti-TSH, antithyroid peroxidase, antithyroglobulin, anti-nuclear, or anti-acetylcholine receptor antibodies? Have a think. Okay, 60% think antithyroid peroxidase. We're going to have a little bit of a chat about particularly antithyroid peroxidase very soon. That's absolutely right. So antithyroid peroxidase, the majority of patients with Hashimoto's have antibodies to thyroid peroxidase. These three autoantibodies are the most important to be aware of in both hyperthyroidism and hypothyroidism. So as we said, kind of over 90% of patients with Hashimoto's have antibodies to thyroid peroxidase. Over 90% of patients with Graves' disease, like we talked about yesterday, which is hyperthyroidism, have anti-TSH receptor antibodies. And then antithyroglobulin can be seen in both conditions. And we'll show you the table that we looked at yesterday as well. We'll have another look at that as well. Anti-nuclear is non-specific, can be seen in conditions like SLE, and anti-acetylcholine receptor is myasthenia gravis. Good, so hopefully we have warmed up a little bit. So let's talk a little bit about our etiology / pathophysiology. So this is the same diagram from our hyperthyroidism lecture. So if you've seen that, this should all be really straightforward for you guys. So what hypothyroidism is a deficiency in circulating thyroid hormones. So your two main thyroid hormones are T4 and T3. So as we discussed yesterday, your hypothalamus produces TRH, thyroid releasing hormone, which acts on the anterior pituitary gland, which produces a bunch of other hormones as well. One of which is thyroid stimulating hormone. Thyroid stimulating hormone then trots on towards the thyroid gland in your neck to make T4 and T3. So in order for us to understand a little bit more about Hashimoto's particularly, and really hypothyroidism in general, we need to know what's going on in the thyroid gland. Well, once we get here, we need to make T4 and T3. The vast majority of the thyroid hormone produced by the thyroid gland is T4, and a little bit is T3. Thyroid gland predominantly produces T4. So in order to produce T4 and T3, we need iodine. And that's why if you have iodine deficiency, you can't produce these hormones to the same degree, and that's why you get hypothyroidism. Now, you have iodine which you take in via your diet, and the iodine goes towards your thyroid gland. Now, thyroid peroxidase, which is that enzyme which in Hashimoto's you produce your autoantibodies to, what thyroid peroxidase does is that it oxidizes iodide to iodine ions. So that's what you need to remember. So thyroid peroxidase oxidizes iodide to iodine ions. And that part of the pathway is what the autoantibodies are targeting. These iodine residues are then, the iodine is then added to tyrosine residues. So the iodine that's now being produced is added to tyrosine residues, which are on thyroglobulin, which is what most of our T4 and T3 is bound to. So iodine is added to tyrosine residues on thyroid peroxidase, and when you have anti-TPO or thyroid peroxidase antibodies, they target that thyroid peroxidase and it activates complement, and it also acts as a competitive inhibitor for the thyroid peroxidase enzyme. So those two main things, you get complement activation and it acts as a competitive inhibitor as well, means that less thyroid hormone is going to get produced. And that's the basic pathophysiology of Hashimoto's, which has your anti-TPO enzyme. And like we mentioned yesterday, you have T4, T3. T4 goes towards your peripheral tissue. It then is converted into T3, which then circulates around your body. T4 is actually inactive and it needs to be converted to T3, which predominantly occurs peripherally, as we said. Good, does all of that make sense? Do we understand this pathway, why Hashimoto's occurs? Yeah, good. The half-lives of thyroid hormones in general are around 5 to 7 days, which is the reason why there's no point in repeating thyroid function tests every other day. If you do an intervention, you really should wait at least a couple of weeks before assessing whether that intervention's been successful because of that half-life. Okay, question time. Which of the following blood results would you expect in this patient who we think has Hashimoto's? So we'll, in the next few slides, talk a little bit more about interpretation of TFTs in hypothyroidism. Okay, gotta get to 250 or so. Let's see. Nice. Nice. Bread and butter stuff. Guys are too good. All right. Let me just close that. Cool. Fantastic. Absolutely right. So, I mean, all of these are high T4, so that's hyperthyroidism anyway. So that leaves you with these two options, and we're going to talk about how to differentiate between these two. But yes, this is primary hypothyroidism, which is high TSH and low T4. So let's have a think about why that is. So focusing now on primary hypothyroidism, the vast majority of cases of hypothyroidism are primary. We're going to have around 95% of cases, give or take. The three main causes that we're going to focus on now are iodine deficiency, autoimmune thyroiditis, under which Hashimoto's will fall under, and transient thyroiditis, which we're going to look at shortly. So let's see our TFT, so thyroid function tests. Overt hypothyroidism in primary hypothyroidism has a raised TSH and a low T4, which makes total sense because this is a problem within the thyroid gland itself. So that's what primary hypothyroidism is, a problem with the thyroid gland to some degree. So that is why you have loads of TSH being produced, meaning that your pituitary is trying to stimulate your thyroid gland to produce more thyroid hormone, but it physically can't. So that's why you have a raised TSH and a low T4, or free T4 is what's normally measured. Whereas subclinical hypothyroidism, as the name suggests, is subclinical, and you can look, if you look at the patient's thyroid function test, you'll see a raised TSH because once again, the pituitary is trying to pump out more thyroid hormone, but actually the T4 is normal. And yeah, it's essentially that's the main difference between overt and subclinical hypothyroidism. So it's not low. So once the thyroid hormone actually gets low, that's when you'll start categorizing it as overt hypothyroidism. Let's talk in a little bit more detail about these three main causes of primary hypothyroidism. So starting from the top, iodine deficiency, most common cause of hypothyroidism worldwide. You need iodine to produce your thyroid hormones. And like we said, less common in the developed world. We fortify a lot of our stuff like salt with iodine, but in places where there's less dietary intake of iodine, that's where it's more prevalent. So worldwide, iodine deficiency is still the most common. In the developed world, such as the UK, Hashimoto's thyroiditis is the most common cause of hypothyroidism overall, and obviously also primary hypothyroidism. So as we mentioned before, Anti-thyroid peroxidase antibodies are being produced, which therefore reduce the production of your thyroid hormone. It normally is associated with a diffuse, painless goiter. That's something to remember. So goiter is just enlargement of the thyroid gland like we discussed yesterday. And if you want more details about goiter and why it occurs, etc., have a look at that lecture webinar. The only other thing to mention is that obviously not all patients are going to necessarily have a goiter. In early disease, kind of relatively early disease, you can get the development of a goiter, but actually in later stage disease, the thyroid can actually become atrophic. So you get something called atrophic thyroiditis. So the thyroid can shrink. So not all patients have a goiter. So in advanced disease, you might actually have a shrunken thyroid because it's become atrophic. That's just an additional point to remember. So patients with Hashimoto's thyroiditis often have a transient thyrotoxic state. So initially, they're not necessarily going to have overt hypothyroidism straight away. They'll often be hyperthyroid initially, and then also known as hashitoxicosis. It's a really cool name, but then eventually will become hypothyroid. And just another point to mention for your exams is that there's an increased risk of non-Hodgkin lymphoma as well. Okay, so there we go. So that's autoimmune, which is the main underlying pathophysiology of Hashimoto's thyroiditis. Now let's have a chat about our transient thyroiditis, of which there are a few types, but the main one we're going to focus on is subacute or de Quervain's thyroiditis. So this, which is also known as, granulomatous thyroiditis, but often that's not used. But if you remember it like this, subacute de Quervain's thyroiditis, which falls under the umbrella of transient thyroiditis. So what normally happens here is that you have a viral infection, like an upper respiratory tract infection. For example, following influenza, following mumps, for example. And normally this would occur a few weeks prior to you developing hypothyroidism. So you'll often have a preceding upper respiratory tract infection. That's what you'll probably get in your exams. And then they'll start developing symptoms of hypothyroidism eventually. So what normally happens is you get local symptoms, kind of exquisite tenderness around this goiter. So that's a really important differentiating feature between these two. Hashimoto's, if there is a goiter, it's normally painless. De Quervain's is normally a painful goiter because of that inflammation. You normally initially have a thyrotoxic state, which is similar to Hashimoto's, which will then become which the patient will then eventually become hypothyroid. As the name suggests, it's transient, which means it's usually self-limiting. Normally you'd start managing it with things like NSAIDs, and then if that doesn't really help, you can then move on to steroids, and then a very small minority of patients will then potentially need levothyroxine in that hypothyroid state. So pretty straightforward to manage and usually self-limiting. Those are the main points to remember about de Quervain's thyroiditis. The only other type of thyroiditis transient thyroiditis that I wanted to mention would be postpartum thyroiditis, which also comes under that umbrella of transient thyroiditis. As the name suggests, it happens after pregnancy, thought to be an autoimmune reaction of some kind, where you normally up to around 6 months after pregnancy, you initially get a thyrotoxic state, so patients are hyperthyroid after pregnancy, and then eventually develop hypothyroidism. Once again, this is normally self-limiting. By around 12 months after birth, the patients have normally returned to normal baseline thyroid function. Those are the main things to know about postpartum thyroiditis. There's various other types of transient thyroiditis, but we've stuck to the main conditions to be aware of here. So yeah, remember iodine deficiency, Hashimoto's thyroiditis, de Quervain's thyroiditis and postpartum thyroiditis. The latter two which fall under transient thyroiditis. There you go. Those are the main kind of components of primary hypothyroidism that I wanted to talk about, but I think it's probably worth that you guys know a few other causes. So the three at the top in bold we have discussed, but also just be aware that there are obviously a few other causes of primary hypothyroidism because of, you know, actual pathology within the thyroid gland. So key drugs to remember. Give me an example, probably the most likely drug that's going to be causing something like hypothyroidism. Okay, interesting. Yeah, I mean, you're right. So I was going to think something like an anti-thyroid drug would be more obvious, but yeah, amiodarone does. So it's estimated, according to NICE, that around 15% of patients with Graves' disease who are being treated with anti-thyroid drugs like carbimazole actually develop hypothyroidism. So that's one example. So carbimazole, propylthiouracil, really anything you're going to use to treat hyperthyroidism can cause primary hypothyroidism, which makes sense. And then, like you guys are mentioning, other drugs like amiodarone, lithium, sodium valproate, for example. There are a few other causes as well. So yeah, just be aware of the main drugs that are associated with primary hypothyroidism. Understandably, if you have ablative surgery or, you know, actual trauma to the neck and you damage the thyroid gland, that can cause primary hypothyroidism as well. And then infiltrative disorders are going to be things like amyloidosis, sarcoidosis as well. So yeah, be aware of those. I guess the other one that could fall under this would be malignancy, but just be aware that patients with thyroid malignancy are usually euthyroid. So that often won't result in primary hypothyroidism, but would fall under that umbrella over there. And then finally, congenital causes like absence or underdevelopment of the thyroid would be a very rare cause as well. Good. So this is actually how NICE also categorize their causes. So they've listed these key causes under their summary of primary hypothyroidism. Okay. Round three, I think, third question, maybe fourth, I lost track. Which of the following is a cause of secondary hypothyroidism? So we've talked a lot about primary hypothyroidism. Nice, straightforward question, I hope. See if you guys have been listening for the past 25 minutes. What do you think is a cause of secondary hypothyroidism? Okay. Lovely. Good. So 3/4 roughly say pituitary adenoma. And you guys are absolutely correct. So as we mentioned, Hashimoto's, iodine deficiency, anti-thyroid drugs like carbimazole, all cause primary hypothyroidism. Graves' disease causes hyperthyroidism, leaving us with pituitary adenoma, which is a cause of secondary hypothyroidism. So let's talk about secondary hypothyroidism. Okay, so the main difference between primary and secondary is that primary is normally due to pathology to the thyroid gland. Secondary is due to pathology within the pituitary or hypothalamus. I'm pretty sure when I was at medical school, this was actually split up into primary, secondary, and tertiary, but looking at the literature and looking at NICE, it looks like everyone now sticks towards, you know, primary and secondary only. So yes, so secondary is dysfunction of the hypothalamus or anterior pituitary. And on your blood results, your TFTs, you're going to expect a low free T4 because it's hypothyroidism, and then a low or inappropriately normal TSH. And just to break that down a little bit, obviously, if you have hypothyroidism, you're going to have a low T4 being produced by your thyroid gland. In physiologically, you know, normal patients, that would cause a reflex increase in TSH production. But in these patients, because of some kind of pathology up here, that TSH is either low, which would be inappropriate, or normal, which would also be inappropriate because you'd expect it to be high. Yeah, so that's an explanation of why you get these thyroid function tests in secondary or central hypothyroidism. Okay, so we'll break this down a little bit. It's a little bit more straightforward than primary. So the most common cause is going to be a pituitary adenoma, followed by something like a pituitary glioma as well. So this is basically usually a benign piece of tissue which is formed within the pituitary, causes compression effects, can also reduce the function of other, the release of other hormones from the pituitary as well, but eventually can result in hypothyroidism. So if you watch our lectures on prolactinomas and acromegaly as well, you'll see that these really pesky pituitary adenomas can do a bunch of different things. So that's your most common cause of secondary hypothyroidism. This also makes sense. If you have damage, radiation, surgery to your pituitary, that can reduce the function of the pituitary, resulting in hypothyroidism as well, because of reduced TSH secretion. Let's have a chat about these two conditions. So this falls under that umbrella of kind of vascular pathology. So pituitary apoplexy is basically either bleeding into the pituitary or impaired blood supply to the pituitary gland, and often occurs because of a pituitary adenoma that is now bleeding. So that's what pituitary apoplexy is. Anyone know what Sheehan syndrome is? Or when it might occur? Exactly, postpartum hemorrhage. So postpartum women who have significant postpartum hemorrhage can, become hemodynamically unstable. They'll go into hypovolemic shock. You get ischemia and essentially pituitary necrosis, that's what Sheehan syndrome is. It's really good to remember that because for some reason, I think they'd like to ask about Sheehan syndrome in exams. Good, so hypothalamic disorders, obviously that's further up along that pathway, can be responsible. Tumors, for example. Sorry, just to clarify, so Sheehan syndrome won't cause major hemorrhage, but obviously postpartum hemorrhage in itself can cause hemodynamic instability, hypovolemic shock, and Sheehan syndrome. Infiltrative disorders as well, similar to the ones we discussed, so things like amyloidosis, sarcoidosis, hemochromatosis are a few key ones that would fall under that. And drugs. So drugs is actually quite interesting. I was a bit weird and read a paper on drugs that cause secondary hypothyroidism last night, because NICE say a few things about this. So I didn't know this, but I thought it'd be interesting to share. So cocaine is actually apparently a really important cause of secondary hypothyroidism. I'm not entirely sure what the exact mechanism is, but if you're thinking about recreational drugs associated with secondary hypothyroidism, cocaine is one of them, along with other more conventional drugs like dopamine and glucocorticoids as well, can result in secondary hypothyroidism. So yeah, those are a few ones to remember. Good. Okay, so a little bit about epidemiology. So we've said, Hashimoto's is the most common cause in the developed world, whereas overall worldwide iodine deficiency is the most common cause worldwide. These are the main risk factors associated with Hashimoto's, but there are also some obvious risk factors that we've already discussed previously, which you could also incorporate into this. So Hashimoto's is far, far more common in females. As we mentioned right at the start, it most commonly affects those middle-aged females, 30 to 50-ish years old. They may have a family history of autoimmune thyroid disease. They personally may have a history of autoimmunity, a couple of conditions mentioned here. And then, anything really, like we've already said, that's going to cause damage to your thyroid, or organs like, tissues further up, such as the pituitary or hypothalamus, can potentially result in hypothyroidism. So that's nice and straightforward, hopefully. few clinical features. That's a pretty boring slide, unfortunately, because a lot of people already know what the main clinical features of hypothyroidism is. They're essentially the opposite of hyperthyroidism. Obviously, the thyroid hormone is responsible for mediating your metabolic effects and sympathetic nervous system, etc. So if it's raised, you're going to get weight loss, you're going to get all the symptoms of hyperthyroidism, sweating, etc. Whereas the opposite is going to be hypothyroidism. So weight gain, cold intolerance, lethargy, and constipation. These four are what our female, right in the initial case, had. Patients can often have dry skin. Menorrhagia, this is also really common in exams. Just remember, classically, everyone always says hypothyroidism is associated with menorrhagia. But also be aware that later on in disease, and this actually isn't particularly common, but later on, women with untreated hypothyroidism can eventually develop oligomenorrhea and amenorrhea as well. Then a few signs to be aware of, like we've mentioned already: bradycardia. You may or may not have a goiter. Loss of the lateral aspects of your eyebrows, also known as Queen Anne's sign, is a nice exam question as well, which often gets asked. Hair loss and hyporeflexia. So a lot of these are just the opposite of hyperthyroidism, but I would recommend checking out the hypothyroidism webinar that we did yesterday. There's one thing that hasn't been mentioned here, which is this. Now, this chap has very severe hypothyroidism, or myxedema, which shows this expressionless face and puffiness around the eyes. Okay, so some investigations to consider. In a stable patient, these are really, really straightforward. TFTs, like we've talked about, you now know what you're looking for. Like we've said, you're looking for primary or secondary hypothyroidism. What do we think the cause is? Have a look at the TFTs. You're then going to request some autoantibodies. Like we've said already, anti-TPO is most associated with Hashimoto's. Vast majority of patients have antithyroid peroxidase antibodies. You can consider testing inflammatory markers. If a patient comes in with a preceding a kind of upper respiratory tract infection, as a painful goiter, you could check inflammatory markers, which would also support a diagnosis of de Quervain's thyroiditis. We then have some investigations to consider. So ultrasound could be considered as well. So this is made, according to NICE, if there's a goiter, focal nodule, or you suspect malignancy, then you're going to be considering an ultrasound. It's also important to note, like we also mentioned, that patients with suspected thyroid malignancy often have normal thyroid function tests. So if a patient has normal thyroid function tests and a goiter or a nodule, actually that is more concerning for thyroid cancer than if someone has abnormal thyroid function tests. Which is just repeating the point I made earlier. So remember, thyroid cancer patients are often euthyroid. And if you're suspecting it, you'll arrange an ultrasound. Radionuclide, well, I should say nuclide scan, not routinely performed, but is often performed for hyperthyroidism. A few additional investigations to consider as per NICE guidelines. FBC and serum B12. So pernicious anemia is, patients with autoimmune thyroid disease are at significantly higher risk of pernicious anemia. So if you're suspecting a patient has autoimmune thyroid disease, you could also consider testing for pernicious anemia. And all pernicious anemia is an autoimmune condition which causes a reduction in intrinsic factor. So there's reduced B12 absorption in your gastrointestinal tract, which then causes reduced B12 and megaloblastic anemia. So that's why you're doing these two tests. As I said, these four you're not going to do in all patients, certainly not, but NICE recommend that you consider these investigations. Fasting lipids, hypothyroidism is associated with hypercholesterolemia. So obviously that's a cardiovascular risk factor in itself. So if you can check those and try and optimize that, that's probably going to be beneficial as well. You can check serum glucose, check HbA1c, and then also celiac serology. So you're going to be assessing for celiac disease. Once again, not in all patients, but if you're suspecting autoimmune thyroid disease, consider testing celiac for celiac disease if they also have, symptoms which are suggestive as well, because thyroid disease is more common in patients with celiac disease. So as well as being aware of these tests, I guess this also has taught you some of the associated conditions with particularly autoimmune thyroid disease, Hashimoto's. So yeah, like I said, these are your main investigations, and these are a few that you will consider. Okay, so this is an exact replica of, I think we've just highlighted a few things now, of the slide that we did yesterday. And just to clarify, you can diagnose a patient with hypothyroidism based on symptoms and blood tests alone. You don't need to start doing any other fancy invasive tests. It's pretty straightforward to diagnose, and is often done in primary care. Some key autoantibodies, it's just highlighting the point we mentioned yesterday. Graves' disease, the vast majority of patients, almost all patients, have anti-TSH receptor autoantibodies, whereas hardly any patients have it in Hashimoto's. So if you suspect a patient has hyperthyroidism because of their symptoms and they're anti-TSH receptor positive, it's almost certainly going to be Graves' disease. It's a similar concept, but reversed with Hashimoto's. So if you're strongly suspecting a patient has hypothyroidism because of their symptoms and they're anti-TPO positive, you can almost be certain it's Hashimoto's. And then antithyroglobulin can be seen in variable degrees in both conditions. So yeah, that obviously these numbers vary depending on what you read in the literature, but these are the main points to be aware of. Cool, is everyone still with me? All of that makes sense to you guys? Yep, good, fantastic. I've done enough talking. Let's have a question. Okay, some of you guys have jumped ahead. Let's so blood results show raised TSH and low T4. What are you going to do next? What are you going to do next? So remember what she came in with. She came in with barn door symptoms of hypothyroidism, and she has those tests. Okay. Oops. Meant to press that. There we go. Yeah. Okay. In reality, you're probably going to check her autoantibodies first, of course, to confirm Hashimoto's, but you can be pretty confident that it is that. So yeah, you probably check for anti-TPO antibodies. But yeah, as you guys are saying, offer levothyroxine. So levothyroxine is T4, which in the UK, probably most countries now, that's what we use to replace thyroid hormone. And it's preferred over T3. So the main difference between these two, so we already know, T3 is mainly formed by peripheral conversion, and that's the active form of thyroid hormone, whereas T4 is produced predominantly by the thyroid gland itself and is inactive. Now, in reality, what we prefer is to give levothyroxine rather than T3. One of the reasons is that T3 is rapidly absorbed by your gastrointestinal tract. So some patients may develop a mild form of hypothyroidism when they're being treated, hyperthyroidism, because it's being rapidly absorbed. So that's one of the reasons we prefer T4 over T3. Now, as we said, this is a really simple case. She's come in, if you were the GP in this case, and you've tested her thyroid function, you've tested her autoantibodies, then yeah, you'd certainly offer levothyroxine and you'd start treating her. I guess the only other, reasonable option here, well, I guess these two are reasonable. Ultrasound, we said you do if you're suspecting cancer or you've got a goiter or, it's good if you've got nodules, for example, you'd consider doing an ultrasound. But yeah, the other one is referral to an endocrinologist. Anyone know just kind of one indication why you might refer a patient with hypothyroidism to an endocrinologist? Exactly. So yeah, so a lot of you guys are saying secondary. So that's a really, really important point to remember. NICE have very few specific guidelines on when you need to do an urgent referral to an endocrinologist in hypothyroidism. But the key one for an urgent referral to an endocrinologist is secondary hypothyroidism. Because obviously you're suspecting pathology further up that pathway that we've seen, like pituitary adenoma, which needs more specialist input. So remember, secondary hypothyroidism, you're going to do an urgent referral to an endocrinologist. Other indications to discuss with an endocrinologist or, potentially do a referral as well would be, once again, if you have a goiter or a nodule, if patients are planning pregnancy, if they have other endocrine disorders like Addison's, then, things get a little bit more complicated. Then you can consider referring to an endocrinologist. But yeah, in this case, nice, straightforward. You're going to offer levothyroxine. Cool. So we've touched on this already. How are we going to manage these patients? So overt hypothyroidism, like we've said, we're going to give levothyroxine or T4. We are then going to review their symptoms every 3 months and review their TSH every 3 months to make sure that things are improving. And once the patient is stable on this, you can then review them annually according to NICE guidelines. The aims of treatment in general in hypothyroidism are twofold, which are totally logical. You're aiming to resolve the patient's signs and symptoms, and you're aiming to get their thyroid function tests normal or near normal. Those are the two aims according to NICE guidelines, which is logical. So yeah, that's what we're going to do with overt hypothyroidism. Subclinical is slightly more complicated. So it depends on the age, it depends on your symptoms, and it depends on your TSH. So if your TSH is significantly elevated, so above 10, and you have a normal T4, then you can consider levothyroxine. If it's below 10, but obviously above the normal range, with a normal T4, then you consider a 6-month trial of levothyroxine if the patients are symptomatic and below 65 years old. So there's quite a few criteria to fill to fit into this category. But yeah, if they fulfill all 3 of these criteria, so blood tests, symptoms, and age, then you can consider giving them a 6-month trial. I guess the only other point to remember is, I guess I've already said one of them, is that initially review every 3 months and then review annually once they're stable. And then also to actually determine these levels, so to actually determine the thyroid function tests, NICE say that these need to be tested on 2 separate occasions, 3 months apart. That's 2 separate. If a patient on 2 separate occasions, 3 months apart, at least 3 months, have these abnormal thyroid function tests up here and down here, then you can consider these management options. So yeah, just remember that you shouldn't really manage them off one thyroid function test alone. Obviously, the question that we asked previously was just for simplicity's sake. So yeah, just remember that. Okay, another question. Okay, what advice would you give a female with hypothyroidism looking to get pregnant? Okay, just to clarify the previous point, NICE guidelines do say 2 separate blood tests, at least 3 months apart. In reality, if a patient has significant symptoms, it's likely, and they have thyroid function tests supporting a diagnosis of primary hypothyroidism, they're likely to be treated based on that. But according to NICE guidelines, you need 2 tests 3 months apart. What advice would you give a female with hypothyroidism looking to get pregnant? So cease levothyroxine, offer radioiodine, increase the dose, reduce the dose, or no changes are needed. Okay. Okay, there you go. So there's a little bit of a split between these. Please don't give her radioiodine. You will make a radioactive child, and it will also make her hypothyroidism worse. So yes, definitely don't do that. Good. So levothyroxine dose needs to be increased. So a few things to be aware of. I mean, I guess this is the key point. If a patient's on levothyroxine for hypothyroidism, early on in pregnancy, they need to be reviewed very regularly because there's an increased demand for thyroid hormone in pregnancy. So you need to titrate those doses very carefully, and most patients will need an increase in their dose because of that demand. So this patient was looking to get pregnant, but also pre-pregnancy, it's important to also consult these patients about why we're increasing their dose, what are our risks associated with hypothyroidism in pregnancy? Well, there are risks to the mum if you have untreated hypothyroidism, and there's risks to baby if there's untreated hypothyroidism. A few risks to mum are things like preeclampsia, placental abruption, postpartum hemorrhage. Those are kind of a few key ones. Preeclampsia, placental abruption, postpartum hemorrhage. And there are also a load of other ones as well, but those are a few important ones. And there are also risks to baby as well. So preterm birth, low birth weight, respiratory distress in the neonate, along with some others as well. So yeah, the key point is remember to consult these patients and make sure that they are aware that they need to be compliant with their medication and their dose is likely going to increase. Okay, another one. Which of the following is least associated with a myxedema crisis? Okay, this is what we're going to talk about next. We thought we would ask you this question before teaching it to you. But yeah, we're going to talk through this in the next couple of slides. So yeah, which of the following is least associated with a myxedema crisis, which is severe hypothyroidism? Good. Good. That's absolutely right. So temperature above 40 is associated with a thyroid storm or thyrotoxic crisis, like we mentioned yesterday. All of these features are associated with a myxedema crisis, as we said. Well, we haven't said, but we're going to say very soon. Yeah, good. So myxedema crisis is an extreme manifestation of hypothyroidism. It's usually patients who have untreated hypothyroidism. And most commonly occurs in patients over 60 years old. A few key causes are here. The literature suggests most commonly hypothermia is kind of and infections are kind of the most important triggers of a myxedema coma. Like we said, myxedema, the word is used interchangeably. In this case, obviously it means very severe hypothyroidism. So I guess all you really need to think about is think of a typical patient with hypothyroidism and make their symptoms and signs really extreme. That will help you to a degree with understanding the features of a myxedema coma. So most patients will have long-standing symptoms of hypothyroidism. which have been untreated, they then will present with kind of the characteristic hallmark is going to be a deterioration in your mental state, as well as confusion, psychosis, etc. Because obviously your thyroid hormones are so low. You then have constipation. Obviously, a lot of patients with hypothyroidism that is untreated could potentially have constipation, but patients may even present with fecal impaction with a myxedema coma because they're so constipated. Bradycardia, hypotension, hypothermia, often very hypothermic as well. That myxedematous face that we saw earlier on with that puffiness and expressionless face, they may have macroglossia and things as well. And then hypoventilation. This is also one of the characteristic features of a myxedema coma. So hyperventilation, this is because of central depression of ventilatory drive. So then you have decreased responsiveness to hypoxia and hypercapnia. So that's a central respiratory depression is what's thought to cause hypoventilation in a myxedema coma. Yep, so remember this table. Often you don't get asked this very much in exams, but it's really important to be aware of when you get to clinical practice. Obviously, this is a very rare manifestation in and of itself of hypothyroidism, and endocrine emergencies aren't massively common other than, DKA, but yeah, this is also important to remember. So a few investigations for myxedema coma. ECG, patient may be significantly bradycardic, they may have heart block, so that's really important to do. And we like to split things up into bedside bloods, imaging, and other interventions as well. Thyroid function tests, so raised TSH and reduced T4 is what would most commonly be expected, which is obviously making sense because, we have primary hypothyroidism is the most common cause. Full blood count can be performed and most commonly shows a normocytic normochromic anemia. Why this occurs is a little bit unclear, but it's thought to be due to changes in your O2 requirement and erythropoietin production by the kidneys. But yeah, that can be seen. You can get a microcytic anemia as well, but I wouldn't get too bogged down in that point. Patients can have hyponatremia, they can have deranged renal function. Why you get hyponatremia, similarly, a little bit uncertain. It could be because you get water retention in patients because they have a reduced EGFR when they're in this really severe hypothyroid state. But once again, when you get water retention, you can get hyponatremia as well. But this is a little bit unclear in the literature as to why this exactly occurs in terms of hyponatremia. ABG, you're going to do hypoxia, hypocapnia and respiratory acidosis because of your hypoventilation. Blood glucose, you're going to look for hypoglycemia. Infection screen as well. So this is going to be, as vast infection screen as you potentially need. So things like chest X-rays, urine cultures, blood cultures, potentially CT heads, those kinds of things as well are really important. And then obviously out of the emergency setting is going to be a lipid profile, hyperlipidemia, and then actually, sorry, this serum cortisol should probably be a little bit further up here, is also really important. You want to do a random serum cortisol in these patients. For those of you who are aware, we're going to be doing Addison's and adrenal insufficiency soon. But patients with adrenal insufficiency or particularly an adrenal crisis can present with some similar features. So when you have pituitary dysfunction, for example, because of pituitary adenoma, you get reduced ACTH being produced from the pituitary, you get reduced serum cortisol, and you can get an adrenal crisis. So that's something that you need to exclude as well. Like, is this a myxedema coma? Is this an adrenal crisis? We need to really investigate and treat for both initially, is what the guidelines suggest at the moment. So yeah, a low random serum cortisol would suggest potentially there could be an adrenal crisis. So how are we going to manage these patients? So general measures, really straightforward: ITU, HDU, NIV, mechanical ventilation may be required. NIV is non-invasive ventilation. Basic things, warming and correcting your electrolyte disturbances are really important. Specific measures are going to be these three, which are really important to remember. So IV thyroid hormone replacement. This is controversial. Some places and some trusts say T3, some trusts say levothyroxine, some trusts say both. So it's still controversial. Often T4 will be given alone as kind of initial bolus and then reviewed. But as I said, this is going to be really dependent on your local guidelines. But often levothyroxine is used, IV. Antibiotics often are used broad spectrum because infection is commonly a trigger. So if you can cover possible infection at the same time, it could be beneficial. So many do advocate broad spectrum antibiotics. IV hydrocortisone, like we mentioned, adrenal crisis can present in some of the features like the confusion, etc. Can also be seen in an adrenal crisis. So IV hydrocortisone should be given until you have excluded an adrenal crisis and your random serum cortisol has returned. Myxedema coma has a high mortality, and here are a few poor prognostic features: elderly, hypothermic, bradycardic. Good. There we go. So yeah, you give the cortisol, you give the hydrocortisone whilst awaiting the cortisol results, because obviously that can take some time to come back. So this is our final question of the day. I hope you have found this useful. Let's have a look at what the question is. Let's make sure everyone is muted. It should be. One sec. So let me do this. Have a look at this question. I don't know how to do it. Anyway, yeah. Have a look, see what you guys think. How do I mute? So, there we go. Okay, can you hear me now? Good. Yeah, I don't know. Zoom is a bit weird. It's not letting me mute everyone else, which is strange, but good. Which of the following is not a complication of hypothyroidism? Prostate cancer. Good. So all of these are complications of hypothyroidism. I think this question should have made harder. Guys, too many of you got it right. So prostate cancer. In fact, there's evidence to suggest that there is reduced risk of prostate cancer in hypothyroidism. We're still tweaking our questions. I think last time we were told they were too difficult. This time, the last question was probably too easy for you guys. So we're trying to get to the right level. So if you guys can please bear with us, thank you. So yeah, like we've mentioned, you get hypercholesterolemia, you can get coronary artery disease, you can get heart failure. So a few cardiovascular manifestations of hypothyroidism. A few reproductive ones are going to be miscarriage and subfertility, and actually there may be a reduced risk of prostate cancer, according to some of the literature. Fine, that's all. I think that's exactly 1 hour. I hope you guys found that useful. All we ask from you guys, please, is if you could please tell your friends about us. Join us at Bite Medicine for Students on Facebook. Thank you so much for your support and your feedback. Thank you. Yeah, Bite Medicine for Students. If you could please fill out our feedback form There will be no Q&A today, but I'm sure they'll be back soon. Yeah, please bear with us as we get our website up and running and upgraded very shortly. I know there's still issues with logging in and signing in. We are still rectifying those, and then the whole app will be up shortly on the website. Yeah, there are issues with loading and things, but we are sorting them out. So please, please have a look at our Facebook group, Biomedicine for Students. And if you have any questions for me specifically, then you can email me at azim@biomedicine.com. I'm not sure if this feedback link here is working. If not, we will have to leave the feedback forms for today. But yeah, we'll hopefully get everything back online really shortly. Good. Thank you so much. And everyone have a brilliant day, and we will see you tomorrow.